Hello, hello everyone. Good afternoon. We are happy that you participate in our session. Please come in. And I want to open our session and say that NTB strategy that publish World Health Organization to have a main three pillars. It's a patient-centered care, it's a bold policy, and accelerated innovation and researches. And we discuss it, this is the three pillars in our session, because our session called Improving Patient Care in MDR-TB. And if you remember some years ago, the MDR-TB care was centralized in TB hospital, in Center of Excellence. Now, when WHO implemented new short regime MDR-TB treatment, we started to treat patients at home. And now it's very important to discuss the three pillars of NTB strategy in your presentation. And I want to mention for speakers that you have 10 minutes for presentation. We need finish our session 3 p.m. because it will occupy the next session. And we recommended 8 minutes for presentation and 2 minutes for question and discussion. Please follow this advice, and I will sometimes show how minutes to leave for presenter. Please to check your time. And I want to introduce my co-chair.
Good afternoon, everyone. I'm Celine Garfin from the TB program, Philippines.
And I forgot to say that my name is Andrei Mariandyshev. Sorry. Thank you very much. Now we can start it. First presentation, examining the fallout points in the pathway to MDR-TB treatment, a gap study in Lesotho. Carolina Kwok, United States of America.
Hi, everyone. Thank you for showing up to this meeting. My name is Carolina. I'm from the Clinton Health Access Initiative. So today I'm just going to talk about a study that we conducted in Lesotho, looking at trying to quantify the losses along the pre-treatment cascade to MDR-TB. Is there a way I can... How do I forward? Oh, there we go. In Lesotho, it's a country that has one of the highest rates of TB globally, and therefore understanding the gaps to care is essential. We know that the pre-treatment cascade experiences a lot of losses, but in Lesotho specifically, we didn't actually understand how big were these losses, and one of our goals was trying to understand and quantify these losses and understand the challenges facing patients in this pre-treatment cascade. And this was done at the request of the NTP, who had already developed this concept previously, and so Chai stepped in to help them carry out this investigation. Previously, in 2015, the case detection rate was 49%, and as a setup for our study, we chose 3 representative districts representing about 57% of all TB notifications. And these were in the 3 districts of Laribe, Maseru, and Tabaseka. And these all have varying contexts. So one is quite urban, one is peri-urban, the other one is much more rural in the mountain areas. So what we tried to do is try to match patients along the cascade using various data sources, and these include registers at the facility level as well as the lab level, and using the laboratory information system where it was available, and then trying to match that to the sole site that initiates MDR-TB treatment, and hopefully tracking patients along that cascade. So this is kind of our matching. It's quite messy, but this was a very complicated process. It involved paper matching to electronic database matching. It involved a lot of name matching. And so from the patient registers, we recorded patient records from 1,428 patients over 14 sites. And then from the laboratory information system, we were able to get 127,000 records. And then for the MDR-TB initiation data, we were able to capture about 1,195. And from there, we use name matching to try to figure out what are the presumptive cases that should have been referred, and then how many were actually tested and found in the laboratory information system, and from those who are MDR-TB positive, and then initiated on a treatment. And so I'll just move on to some of our findings. The major drop-off points from the get-go was at the start in identifying the right cases for appropriate referral for DR-TB testing. And it's the point of referrals. So what we estimated based on just the records that we obtained at the facility level, we lost about 89% of the patients that should have been referred. And these are patients that are just high risk. So patients that we're looking at minors, HIV positive, previous retreatment cases. Already there, 89% that should have been referred were never referred, or we could not find them in the system, at least in the laboratory system. So that's actually a huge opportunity for us to try to improve that. And one of the challenges that we found when we were looking at the facilities was that only about one out of 14 sites had actually job aids to help clinicians make these right decisions. If there was an algorithm or clear outlines of what patients should be referred for DR-TB testing, either in the registers or on a piece of paper, I think that could be very helpful going forward. And this is corroborated by some of the findings that we taught after interviews with the clinicians, where we found only 7% of the clinicians that we interviewed actually understood which patient should have been referred and how the process for referral should have been done. For the clinicians that knew which test to refer, most of the clinicians knew that they should be referring for DST and culture. But we also saw tests that were outside this algorithm, including blood cultures and urine LAM, which are not in the national guidelines. So that's an opportunity for improvement. The second major area that we looked at, that we found major drop-offs, was basically from the lab when we identify an MDR case to initiation. And part of that, it relates to the long delays in sample processing and results delivery. From what we see, when the sample is received in the laboratory system, it should be marked in cultures and in LPAs. We are seeing over 80 days until the result is actually entered into the system. Now, whether that's an issue of data entry or actual sample processing, that's something else that we needed to look into after the study. But that's already a huge delay that we may already experience losses to patients along the cascade. But the more significant part is the results delivery, where we're seeing an extra almost 100 days for a patient to actually get their results. And this is corroborated by some of the clinician interviews where we saw that the clinicians were reporting that they didn't receive results for 7 to 8 months after sending in a sample. So this is a huge reason for some of the patient losses that we're experiencing along the pre-treatment cascade. However, in the sample districts that we saw, for those that actually were identified in the laboratory system and that we actually found, 25 were initiated onto treatment. So that's encouraging for these districts, but there's a huge component in the other districts that we're also seeing the losses. So from what we see from just the laboratory information system, we have about a 60% loss of all these patients to initiate MDR-TB treatment. And in Lesotho, there is only one place to initiate treatment. So what that database provides is everybody that we know of that has received MDR-TB treatment. So it's quite reliable to understand that loss. So the common challenges that we saw were basically sample collection and transport, laboratory processing, results delivery, and across the board, just data capture generally. We know that the sputum production is very challenging for patients. Often patients are sent home to produce additional samples but never return. Oftentimes there's a lack of refrigeration because of electricity, so they can't store the samples. So often clinicians just refer them to the sample collection site, and often patients don't go because it's quite far, and Lesotho doesn't have a very strong infrastructure or transport system there. And sample transport, as I mentioned, is a big challenge. Seasonal, so in the winter, oftentimes roads are not accessible by the sample transporters, such as Riders for Health. So they cannot transport these samples in a timely manner at times. Laboratory processing, like I mentioned, could lead to some of these delays that we're seeing. Oftentimes, labs are reporting that they can't run tests. They don't have necessary refrigeration. Sometimes they run out of reagents. Results delivery and communication. There was a huge delay in results delivery, as we showed. But there was also communication gaps. The facilities reported that they don't actually want to send samples forward because they actually don't receive anything back. So the trust in that system to make sure that the laboratory is processing the samples wasn't there, and so oftentimes that was a big break. And then notifiable cases are only alerted to the NTP, but were not always notified down to the district or MDR-TB hospital. So the whole chain wasn't connected in the right way, in the same way, so that a notified case wasn't actually identified to all levels of care simultaneously. For data capture, like we mentioned, there's some data fields they would be helpful to have some data fields to clearly identify patients to be referred for DR-TB test referral, especially in the TB suspect register. There are no records of referrals, actually. A lot of referral slips are discarded after 1 month, so actually tracking a referral is very difficult. Sometimes LIS results were not captured in the patient records, so actually understanding whether a patient received a positive sputum sample at the 5th month and should have been referred is not actually found there, and so the clinician can't make the appropriate clinical judgment to make the appropriate referral going down the road. And patient information to aid in contact tracing wasn't available, or it was often not captured. Oh, sorry. So what has this translated to, and how has this affected the work in Lesotho? So one of the things that has changed is the NTP has revised the TB suspect and patient registers to capture more of these risk fields. There's been an assignment of responsibilities for case finding and ownership of these registers, which wasn't there previously. As we identified, there was a huge issue with sample collection and visibility. So there was a barcoding project that was initiated to increase the visibility and accountability along the sample transport system. And then in terms of laboratory processing and results delivery, they're implementing a dashboard in the LIS system and exploring the possibility of SMS functionality in the current LIS system, which exists for EID, but not necessarily hasn't been activated for all disease areas. And notification, patient tracking, the NTP is in the process of formalizing notifications of MDR-TB cases to all levels, not just the district level or the NTP level, but also to the MDR-TB hospital, so that everybody's on the same page. And since then, we've seen a more formalized communication between the National Reference Laboratory as well as the MDR-TB hospital, and that's a positive outcome of that. So I'll just conclude. Thank you very much. I just want to acknowledge the NTP, Ministry of Health, LIS officers, partners in health, the FELA Health and Development Communications, and all our health and laboratory staff members. Thanks.
Presentation and in time. Any question? Thank you. Thank you very much. The next presentation, an innovative approach for designing and implementing drug-resistant tuberculosis treatment at high-risk intervention. Hey, Algeria Flores. Yes.
Hello, good afternoon. Thank you for having me here. And I wanted to start today by talking about how I got into the studying MDR-TB. The first time I came in contact with patients was 5 years ago when I did my master's degree in public health. I went to collect data in Peru. And the one thing that really surprised me the most was that most patients, even though I was the one stealing their time for about an hour and a half, asking them a million questions, they were so thankful for having somebody to ask them about their lives. Just how are you? Somebody who cared and had the time and took the time to talk to them. So and that comes from knowing that during the process of treatment, most of these patients don't really get the services, the care that they need to be able to complete treatment and do so effectively. And so this time around, when I went back to do my thesis for my dissertation, I wanted to focus on that process, that period of treatment, when we know adherence is so crucial, but it's also very difficult for so many patients. And many patients actually do very well. They go every day, they take their medications, even though they have the same problems as many of the other patients have. They have problems with the side effects from the medication, socioeconomic issues. They're sad often and anxious about their treatment, but they still go ahead and finish. So there's obviously some kind of a difference there, and I wanted to figure out what that was and how we can figure out ways to have interventions that are really effective and really get to the root causes of these missed dosages. Why don't they come to take a treatment 1 day, 1 week, 1 month? Why do they abandon or get lost to follow up during treatment? And so that is why I did this study. And really the focus is on not thinking about what the treatment outcomes are, because we know the treatment outcomes at the end, we can measure them, we do measure them all the time. But we need to focus, I think, more, based on what I heard from the patients and the providers, really focus more on the process, because during the process is that we have non-adherence. During the process, if that all of these problems come up with patients, and somebody needs to help them facilitate the process so they can actually continue and finish this very, very long treatment. What I wanted to do with this study was try to figure out, finding a tool, some kind of a tool that's going to help us really understand the root causes and also help us measure these interventions' effects if we have any interventions, and hopefully many of you are working on those types of interventions in the room, so that we can measure the interventions properly and really deliver what the patients need to be able to complete the treatment. So what I did for this study, sorry, I'm getting a little confused on the order of things. Okay. Okay, so the objective of my study was to estimate the effects of a model that I found that has been used in other fields. They have been using it as a theoretical basis to design behavioral interventions. And it has worked very well in HIV and diabetes and reproductive health issues, usually with the idea to improve adherence to whatever treatment people are using. And I wanted to adapt that to tuberculosis, to MDR-TB in particular, and see if it could be, first, if it actually could be applied to MDR-TB, if we could predict the health behavior, which is adherence, and then see if we could use this to design, monitor, and evaluate interventions that are targeting adherence. And let's actually go back, and I'm going to explain a little bit of what that model looks like. So in the model, as you can see, the health behavior at the end, that would be adherence. The original IMB model has health behavior information, health behavior motivation, and health behavior skills, all of that leading to the actual health behavior. And the information pertains to anything that has to do with how much knowledge a patient has about the disease and how important they know that adherence is. And then motivation is how much they want, right? They want to do the treatment. So whether that's internal motivation or external motivation. And then the behavioral skills have more to do with somebody's self-efficacy. How well do they think they can actually do this behavior? And all of that leading to health behavior. Okay, so it was a cross-sectional study. I used questionnaires applied to patients and their providers, medical histories, administrative data, and also observational data. I interviewed adults and patients who had been in treatment for at least 12 days. Also talked to nurses, nurse technicians, physicians who actually had daily contact with the patients, and used structural equation modeling for the analysis. And these are the ethical approvals that I obtained. Okay. The original model that I used, you can see on the right side, the original IMB model is adherence information, motivation, behavioral skills leading to treatment adherence. But I also included a couple of other factors that I really found during my previous qualitative study to be incredibly important, that patients reported to be incredibly important. And one of them is, of course, the social networks, the support that they get from them, the provider's work engagement, which means how enthusiastic and how happy a provider is with the job that they do, and then also the previous experience with TB treatment, because many patients would tell me that because they had a previous bad experience or positive experience, that also made a huge difference in their treatment. And treatment outcome is not something I measure, but just so you know that that's what it leads to. It's there. So I went to 11 districts in Lima, 40 health centers. These are the ones with the highest prevalence of MDR-TB in the city of Lima. Interviewed 86 health service providers and 326 patients. And these are some of the description of, this is the patients. And as you can see, I had all types of drug-resistant patients in my sample. And my patients, I interviewed them wherever they were at their treatment. So some of them had been in treatment for a month, some of them had been in treatment for 6 months, a year, some of them were almost done. And you can see the prevalence of HIV in Peru is really low compared to many other countries. But we do have diabetes comorbidity that's actually growing in the country. And some more description about the patients. I did measure the adherence information, motivation, and behavioral skills, how much the patients reported feeling emotionally supported or financially supported by family, friends, their jobs. And of course, I also went to see whether or not they felt like the psychologist on site or the community health worker were people that maybe supported them also. And these are some of the descriptive data for the providers and the health centers. I want to point out that in Peru, DOT is not really implemented as intended often. So if you look at the health centers towards the bottom, pretty much more than half of the health centers did almost never or never really implemented DOT. The nurses, of course, are really busy. They have many, many patients to look after and administrative work to do, so they cannot always be there for the patients. And this is the results of the model. So in structural equation modeling, you can modify the model in order to fit your data. And then you are going to see if there are statistically significant differences, effects or not. So as you can see, I moved all of the supportive network. They are factors that affect information or motivation. And I had to move providers' work engagement. I realized it was a direct effect on treatment adherence. It didn't come through any of the other measures, and also previous loss to follow up. As you can see here, all the ones that have stars or 2 stars, they're all statistically significant results. And you can see that information does not directly affect treatment adherence. It affects treatment adherence through adherence behavioral skills, the same as motivation. It also goes through adherence behavioral skills. And you can see also that the supportive network, which is a latent variable, is also very important for information as well as motivation of the patients. And they did not directly have a strong effect on adherence, but definitely through information and motivation. And also the support by the health service provider is incredibly important because they're in contact with the patients every single day when they go to the health center. So we see that there is a good fit of the data to the model. And we also see that there are other components, of course, other measures, other problems, or I guess in this case, facilitators that really help with adherence. Went too far. Okay. So in conclusion, the model actually did successfully predict MDR-TB treatment adherence. And we do know that there is a positive effect of information and motivation, but only through behavioral skills. And patients did need that support, either from providers or from their family members or social networks, to have higher levels of adherence. And also, since we see that it actually fits the data, this model, this IMB model, we can use it actually to not only design interventions that specifically target information and motivation, and hopefully lead to self-efficacy, high levels of behavioral skills. But we can also use them to monitor these interventions over time and to finally evaluate if they actually had a positive effect on adherence in the end. But we can also tell which components of these interventions or strategies need to be modified if we want to improve their effectiveness, because we can see if they actually had an effect on information directly, or motivation directly, or if they had an effect maybe on behavioral skills directly. And so by breaking this apart, we are able to now improve these interventions with more detail. We don't just say, well, the outcome was better. We say the adherence process, all of the adherence over time throughout treatment was better, and we can say what about the patient's needs were actually met, whether it was information, motivation, or behavioral skills. So I really like this model. I feel like it would be very useful and also would standardize the way we measure, well, design and measure interventions, because it is very difficult for behavioral change, as you all probably know here. So these are my recommendations, is kind of using these in future studies. And also in the future, I think we need to look more of the timing of these interventions, because we're working now with, well, yesterday I think there had been some new regimens that came. They are 9 months long for MDR-TB patients, which is fantastic. But we do know that most of the loss to follow-up happens in the first 6 months, at least in Peru. That is always the case. That is when all the patients have all of these problems come together and have a really hard time sticking with the treatment, or have a lot of days that they missed. So we need to understand the process of treatment. When is it more difficult? Why is it more difficult for the patients to adhere to treatment during those times? And also make sure that the interventions are appropriate at each different stage of treatment. Yeah, I think this tool could be used. Thank you.
Second presentation, just a moment, maybe anybody to have a question for the presenter, please. Microphone is here.
Hi, thank you very much for that presentation. I just wonder, in all of this, did you look at socioeconomic status of the patients as a factor affecting adherence? And what do you think about other incentives and enablers that people have been using, aside from behavioral interventions, as important in looking at adherence?
Right. I do have that data. I only found statistically significant results for the socioeconomic, for income level, for the first stage of treatment. So that's the first 6 months during the injection period. But it's not so much how low or how high a person's income is, but whether or not they feel like it actually limits their ability to adhere to treatment. But even if somebody's income is low, if they have a nice support system who's going to help them financially, that's not really an issue. Some people stop working altogether, cousins, uncles, parents, somebody helps out. So it's not so much, unfortunately, my survey didn't have the question of, do you feel that your income level is prohibitive to your treatment? But I did measure income, and that it's usually not enough. You can help them out if you feel like they need it, but it's really whether or not they feel like they need it. If they have a support system, that's not an issue, which is why also those components kind of help figure that out, because the self-efficacy component that's where that would go. I think the socioeconomic, more the income level. You can know that you have to adhere, so that's the informational component. You can want to adhere, and that's the motivation component. But if you don't feel like you actually can do it, which is the self-efficacy, sometimes it is because of barriers like income level. But again, you can facilitate that through other means. Either they have their own means to facilitate that, or in those particular cases where it's actually an issue, then you can bring some kind of a strategy, maybe give them a little bit of help with food, all those types of incentives. And I've looked at a lot of facilitators as well, enablers, different types of interventions that people have applied. The issue with those interventions so far is that they usually go for the outcome at the end. They don't really measure adherence. So we don't really know whether or not they help somebody for a particular reason, why they help them. Some of them work, some of them don't work. They're usually small scale. So I really feel like if you really want to understand why some of these interventions work, we need to look at things like, how a patient feels about it, and whether or not that actually increases their ability, their information level, their motivation level to actually go on with the treatment. Yeah.
Thank you very much. Time is our. Thank you for the fine presentation. The next presentation, impact of gene expert testing on treatment delay among persons diagnostic with drug-resistant tuberculosis in Johannesburg, South Africa. presenter, speakers, Dennis Evans. Please.
Thank you. And thank you for the opportunity to present some of our results on this work. I'd really like to thank my co-authors because this was really a ton of work. So I'm going to talk today about the impact of expert testing and decentralization of care on treatment delays among persons diagnosed with drug-resistant TB in Johannesburg, South Africa. So prior to 2011, all RIF-resistant TB in South Africa was treated at inpatient facilities for the duration of the intensive phase of treatment. On average, this is approximately 6 months. Time from sputum collection to inpatient admission ranged from 10 to 16 weeks, and approximately 40% of patients died before starting treatment. In response to this, the South African government implemented 2 major policy changes in 2011 and 2012. First was the outpatient initiation and administration of the intensive phase of drug-resistant TB treatment, and also expert became the standard diagnostic test for TB. The overall goal of these new policies was to improve drug-resistant TB diagnosis, treatment initiation, and treatment cure rates. So expert, it has been shown to reduce the time to diagnosis. However, there is less evidence for reducing time to treatment initiation. So this schematic shows the procedures and systems in place for a patient with drug-resistant TB treatment at the district level. So a symptomatic patient will present at the primary healthcare clinic. They will provide 1 to 2 samples, a sputum collection. That is then sent to the National Health Laboratory Services for testing. The result is then sent back to the primary healthcare clinic, as well as to the City of Johannesburg TB coordinator. A case registration number is then assigned, and the district TB coordinator is then notified of the result. The district TB coordinator then traces the patient either telephonically or through home visits, and then refers the patient to an appropriate drug-resistant TB treatment center. At the primary healthcare clinic, the result is then recorded in the TB suspect register, and then the patient is also traced and referred to the appropriate treatment center. On arrival at the treatment center, the patient is initiated onto treatment, and the case registration number is also recorded then in the TB register. So the aim of our study was to determine the proportion of patients diagnosed with RIF-resistant TB who initiate drug-resistant TB treatment, and how long it takes them to initiate treatment during different phases of implementation of expert in Johannesburg, South Africa. More specifically, we aim to describe the characteristics of patients diagnosed with RIF-resistant TB, estimate the proportion diagnosed with RIF-resistant TB who then initiate at one of the city's 4 public sector treatment sites, estimate the time from sputum collection to treatment initiation, and to see if that differed by any factors. So this was a retrospective medical register review with pre- and post-cohorts. This included adults with a laboratory-confirmed RIF-resistant TB diagnosis, and they were also, the City of Johannesburg were notified of the diagnosis, and the patients were assigned a case registration number. Our primary outcome was those that had linked or matched, and this is where they initiated drug-resistant TB in one of those 4 clinics in the City of Johannesburg. Secondary outcomes included where patients had died before treatment initiation or were lost before treatment initiation, and this was based then on the tracing outcome recorded by the district coordinator, and the date that we used there was the date of last contact with the patient. So the cohorts, we have a pre-cohort or what we also termed early or limited expert coverage, and that was from July 2011 to June 2012. We allowed a transition period between July 2012 and June 2013, and then a full expert coverage or post-expert period from July 2013 to June 2014. So patients were followed from sputum collection until the earliest of treatment initiation, death, an outcome or a tracing outcome, or 6 months of follow-up. The data that we used came from the city of Johannesburg. Here we used an Excel register of diagnosed patients and also paper records of tracing activities. We also used electronic patient registers from the 4 sites, the 3 decentralized and the 1 centralized site. For the statistical analysis, we used Cox proportional hazard models to identify predictors of treatment initiation during the different implementation periods. So our results, we had 594 cases in the early expert period and 713 in the full or the later cohort, the post cohort. And these were similar in terms of gender and age. You can also see we had an increase in the proportion that were diagnosed by expert. This increased from 43.4% to 60.5%, and this is consistent with what has been reported nationally. We also then showed a decrease in the time from sputum collection to diagnosis, and this decreased from 26 days, a median of 26 days to 2 days. For our smear positives, this number is lower than what has been previously reported, and that's normally around 45, 46%. However, we had a lot of missing and unknown microscopy status in the data set. For HIV positive, particularly for the full cohort, this was close to what has been reported nationally. Here we report 47% nationally from the electronic drug-resistant TB register as around 52% for patients that have initiated treatment. So this is to show you the results from the linkage to care. So the early or the limited cohort, we had 594 cases diagnosed with RIF-resistant TB. Of that, 61% were correctly or referred for treatment. 18% died, and an additional 18% were lost before they could initiate treatment, and 4% transferred or moved to another facility. Failed to link, of those that were referred for treatment, 18% failed to link to care. So in total, we had 43% that initiated treatment, and of these, 66% were at the decentralized facility. When we look at the full expert cohort, we had 713 and 70%, so a 10% increase in the referral. Mortality before treatment could be initiated decreased from 18% down to 6%. Loss to follow, however, increased from 18% to 22%, so a 5% increase there. Transferred were halved from 4% to 2%, and those that were referred to treatment that failed to link decreased from 18% to 10%. So in total here, those that initiated treatment increased then from 43% to 60%. And here we also see an increase initiating at the decentralized site up to 87%. So then we looked at time to treatment initiation, and here we saw a decrease in time to treatment initiation from a median of 33 days to 14 days. We also showed that patients that initiated at a decentralized site, those that were diagnosed by expert, and also then in the full coverage, those that were HIV infected had a shorter time to treatment initiation. If we look at those that initiated within 5 days, which is which the Department of Health recommends, that increased from 6% to 19% in the full cohort. So when we also looked at predictors of linkage, and here there were no surprises, this has been reported and this is consistent with what is in the literature. We found those that were smear positive, those diagnosed by expert, and we also found those that lived close to the clinic, so within 12 kilometers of the clinic, and those also that lived very far, so more than 54 kilometers from the clinic, were more likely to initiate treatment. So in conclusion, time to diagnosis reduced substantially from 26 days to 2 days. The proportion of drug-resistant TB patients who initiated treatment increased from 43% to 60.3%. Consistent with WHO global TB reports for South Africa for the same time periods. So the proportion initiating within the 5 days increased from 6% to 19%. And time to treatment initiation fell by 20 days to a median of 14 days. Mortality before treatment initiation reduced from 17.5% to just under 6%, while loss to follow increased by 5%. So this was an important finding because it highlights the need for health system strengthening in this particular area, because this is where neither decentralization nor expert could reduce the loss to follow before treatment initiation. So decentralization and improved diagnostics alone are not sufficient. Improvements to link patients diagnosed with drug-resistant TB to effective treatment remains a high priority. And then lastly, I would just like to thank all our co-authors and supporters as well as the City of Johannesburg.
Yeah, thank you very much, Danny. Really, it's fast diagnostic MDR. It's crucial for implementation MDR-TB care. It's really, it's improved result of treatment and of course decrease the mortality rate. Any question? Yeah, please.
Thank you for the presentation. Just as a follow-up, even though it might not have been your primary objective, did you find out if there were any systems within these facilities to contact people who had been found to be expect positive and RIV resistant? For example, when the result gets back to the clinic and the person
at the primary health care?
Yes, at the public health facility, was there an existing system to contact that person to say your result is positive, you have RIV resistance, please come back?
So according to that guideline and the schematic that I showed you, it says that the primary healthcare clinic should then also, from their side, phone and contact the patient and do home visits to notify them of their result and refer them to the appropriate drug-resistant treatment site. But we didn't do that ourselves. We didn't actually then go to the diagnosing facility and see what systems were in place.
Whether it was being done or not.
Yes,
Okay.
yeah. So we just took it from, our tracing came from the City of Johannesburg register where the outcomes were recorded, the tracing outcomes were recorded there. But we didn't then go to each diagnosing facility and see their outcomes for tracing.
Okay, thank you.
Thank you very much. Thank you. The next presentation. Thank you. Thank you. The next presentation, improve access to MDR-TB service via decentralized service delivery model in Amhara and Oromia region, Ethiopia, Didu, Jerena, Ethiopia. Please.
Okay. Thank you very much for the opportunity to speak. So mine is more of an operational experience of decentralizing services in Ethiopia and two large regions of Ethiopia. So to give you a bit of background about Ethiopia, this country is located in the eastern, in the Horn of Africa, and Ethiopia is among the countries with high TB, HIV, and MDR-TB burden. It's actually the third, and we have, according to the national survey, MDR-TB burden is about 18% among retreatment cases. So when we started this support in 2011, there was a significant gap in accessibility of MDR-TB services. Treatment was being provided in a single tertiary center in Addis Ababa, and patients had to fly from a kilometer of about 700 or more to get the service in this center. So in 2012, we supported the Ethiopian Ministry of Health to develop a model of care, which we call the ambulatory model of care, and in which patients are transiently or temporarily admitted to a treatment initiating center if needed, and then they are transferred to the treatment follow-up centers, which are usually primary health care centers for follow-up. So what we are presenting here is the experience of this decentralization and how it contributed to improving service accessibility in the two big regions. So these are the interventions which contributed to the decentralization of the services. The first one is strengthening the national and regional MDR-TB program coordination by supporting with the development of the guidelines, with the placement of staff, training, and SOPs. Then we also supported with the renovation of treatment initiation centers. Providing the treatment was very difficult in the existing facilities. So we had to build annexes to the existing hospitals and create a center where patients can be treated safely and get quality care. Building the laboratory capacity in terms of initial diagnosis and follow-up was another intervention. We provided job aids, patient education materials. We also assisted with monitoring and evaluation of the services. So patients were coming for follow-up to the follow-up centers very close to their homes on a monthly basis, where we also did screening of their household and other close contacts. So these are the intervention packages which contributed to the service expansion. As you see here, in 2012, we didn't have any gene expert center in the country. It was 0. So we expanded it from 0 to 49 sites, providing rapid diagnosis using gene expert. The treatment center, as you see there, is in red on the right side is the original treatment initiating center, which is a tertiary care facility. So patients had no access. So we expanded using the decentralized service delivery model to 24 sites. So the experience I'm presenting is about these 2 regions, but currently we have even more sites providing the service in Ethiopia, and it has been expanded massively. So as a result, if you compare the baseline values, number of treatment initiation centers has increased from 1 to 22. Treatment follow-up center, there was no treatment follow-up center. We had to provide it in a single center, both the treatment and follow-up. So we have more than 300 centers providing the service in the 2 regions. And our number of TB cases screened or tested for MDR-TB has increased about 14-fold, which is from just 600 to more than 9,000 in a year. And annual number of MDR-TB patients enrolled and put on second-line drugs increased from 56 to 325. So this number is a bit outdated. We have more patients now, but this is just to show you how decentralization of services has contributed to tremendous improvement in service accessibility. And the cure rate, the global average as of last year was 48%. So with this decentralization, one of the concerns with many experts was the quality of services. So if we measure it in terms of cure rate, then we have 70% cure rate from this decentralized service delivery models. At baseline, it is much lower, but there are factors that have contributed to that because the patients during the initial phase of treatment, of course, were having more advanced disease because of lack of access, total access to the treatment. So in conclusion, so decentralized MDR-TB service delivery model, the ambulatory care model, has contributed to a significant improvement in access. There is also progressive improvement in the quality of services and treatment outcome from baseline until currently. And we think this kind of ambulatory care model is feasible, and this should be recommended for countries with high MDR-TB burden. Thank you very much.
Thank you very much, Tego. Anybody to have a question? The presentation was very concrete, and we have a time for question. And thank you. Thank you very much. Thank you.
Okay, so let's move on to the next 4 presenters. So the next would be on achieving rapid scale-up of MDR-TB treatment using a decentralized mixed model of patient care, lessons from Uganda. So our speaker is Stavia Turiabhabwe from Uganda.
Good afternoon to you. Achieving rapid scale-up of MDR-TB treatment using a decentralized mixed model of treatment for MDR-TB patients. Uganda is found in East Africa. It is a landlocked country. Our population is about 35 million. Most of it in the rural setting, only 18% urban. Our growth rate is about 3%. TB prevalence, we've just conducted a prevalence survey, and our prevalence is 253 per 100 population, and we notify about 114 cases per 100 population per year. Our TB HIV co-infection is 41%, and our treatment success is 80% for susceptible TB and 74% for MDR-TB. We have one national TB reference lab, which is also a supranational reference lab for the region. We have 1,300 microscope centers and 112 gene expert machines in 79 districts. So that's where Uganda is found in Africa. We are among the 30 high-burden TB-HIV countries, according to the most recent WHO report, with our annual notification of TB of about 47% TB cases. The MDR-TB prevalence is 1.4 among new TB cases and 12.1 among previously treated TB cases. So we are considered not a high-burden country for MDR-TB. In 2012, the country had a high burden of people who were diagnosed with drug-resistant TB, but were not able to access treatment. Over 300 MDR-TB patients had been diagnosed, but were waiting to start treatment because we had not started programmatic management of MDR-TB as a country. We had a few centers who were supported by partners that were managing MDR-TB, but still at a small scale. They could not absorb the numbers. And the treatment model then that we had was mostly for admitted, patients had to be admitted for them to start on treatment. Yet we did not have admission capacity at that time. The only diagnostic model was based on full DST, and this meant that a number of cases were going undiagnosed for their MDR-TB. So what did we do? With support from USAID, especially Track TB project, Global Fund, and other partners, the country decided to adopt a mixed decentralized model and expanded the treatment initiation facilities. So we had patients who are starting on treatment as purely outpatients and patients who are starting on treatment initially as admitted patients, and they would be transited to the ambulatory care model because of the lack of capacity for admission. We also had to increase the capacity of health workers, so we brought on board a number of health workers and trained them in MDR-TB management in the different regions that we brought on board. We provided them with the necessary logistics. We supported peripheral health facilities that provide DOT because patients were going to be treated in the community. Supported contact investigation and screening. And then the partners helped us to give patients transport refund so that they can continue to come for their DOT sessions. So our patients attend the facilities, mainly public health facilities nearest to them on a daily basis to take their DOT. Every month, they also come to the treatment initiation facility so that they can be reviewed by the clinician, and also they are monitored on treatment, so they provide samples for laboratory monitoring. We also introduced cohort reviews as part of capacity building to the health workers, but also to improve on the quality of care that was given to the patients, given the kind of model that we had adopted. In 2013, we rolled out the Gene Expert technology to improve on the diagnosis and detection of drug-resistant TB. So we were able to bring on board 13 more treatment initiation facilities, which covered all the regions of the country, a 5-fold increase in the number of treatment sites, and about 11-fold increase in patient enrollment. Most of our patients are male, and this was by 2015. The numbers have increased of late. So the pink circles indicate the treatment initiation facilities, and the stars show us the hubs where samples are collected, and then the triangles are the Gene Expert sites. You can see at least every region of the country has a treatment initiation facility and a diagnostic unit. Okay, so treatment enrollment over time as we introduce the changes, you can see most of the number of patients increased over time from 2012 when we started, and has been increasing since. And this year, there are many more patients that have been identified and started on treatment. The number of patients who are getting DOT from the treatment initiation facility is less for most of the years than the number of patients that get DOT from the peripheral facilities. Most of the patients are in the field, in the peripheral facilities. We have over 400 of them. During the cohort reviews, we look at the patients for their interim outcomes, 6 months interim, and also look at 12 months progress so that we know that whether the health workers are on track in managing the patients and the patients are getting quality of care. And we find that 78% of our patients by 6 months have become culture negative. Our treatment success is at 74%, which is, I think, acceptable. Decentralization of care and patient ambulation address the gap in access to MDR-TB treatment. And the cohort reviews, mentorships, and monthly patient clinics at the initiation facilities have continued to improve the capacity of health workers and also the quality of care to the patients. So increasing access to optimal treatment is critical for MDR-TB control and prevention. And decentralization and use of mixed model of patient care rapidly improves access to treatment with optimal outcomes. This approach is recommended to settings that are facing similar challenges like we had. If we have patients who are out there with the disease but are not accessing treatment, it is possible that you can treat patients even when you do not have a ward Because if you don't start them on treatment, they're out there transmitting the disease. You are better starting. Thank you.
Are there questions?
Thank you very much for the very informative presentation. Your treatment success, you said it's 74% for MDR-TB, which I think is really high. Can you give us an idea of what it was like before you started the decentralization, whether that increased from the intervention? And also there's a question I wanted to ask for the presentation from Oromia and Amara to find out if they have any idea of what the treatment outcomes are after the decentralized. Thank you.
Like I said before we decentralized, most of the patients were being managed by partners, and there were a few patients that were in care. In 2012, we had about 40 patients who initiated treatment, and our success was about 85%. So when we decentralized in 2013, it has dropped. We don't know what the 2014 cohort will show us. But at least we were able to treat many more people, and the success is still acceptable.
Will Dr. Degu? Because there is a question for Ethiopia. Okay, one more question.
Good afternoon, all. Thank you for your presentation. My name is Messi Omozwanfo. I'm from Nigeria. I'm just wondering, during your presentation, you said in your country you have just one reference lab. And I'm looking at your outcome rate, about 74%. So I'm just wondering, I'm curious, I want to know, what are the processes or what is the turnaround time for your sample result to come out, like sputum culture and so on? So how do you measure that, the outcome that you have presented to? Does it mean that as soon as you send these samples, the result come almost immediately? Because I know that we have issue in our country that where you send sample, it takes several months for this to come. We're having issue in measuring our outcome. So I want you to enlighten us the more. Thank you.
Yeah, thank you. Yes, we also have issues with turnaround time, but at least with the institution of the cohort reviews that we do, where we bring on board the lab teams, we bring on board the clinicians who are managing patients. We've been able to reduce this significantly, and the lab has put in place a system to communicate with all the treatment centers and relay the profiles of each of the patients in time. So our turnaround time for culture results is about 8 to 12 weeks. DST is the one which takes a little bit longer for some patients, especially when your sample gets contaminated. We find ourselves going beyond 12 weeks and so on. So by the time we do, like this 74 is for the 2013 cohort, so we're able to have looked at all their cultures by this year.
Okay, thank you. So our next presenter will be sharing on the management of MDR-TB, transition from hospital to community-based management in Bangladesh. So we have Dr. Reflowe Matji from South Africa. Why? It's different.
No, the other one?
Different presentation. No, that's not.
Previously presentation.
Management.
Standing up. To present is already an anxiety, and as I was sitting there, I was thinking, this podium is so high, will I be able to appear? But I've come down now, I realize that definitely, at least my face does have through, but let's hope the presentation will.
Or can we have this
The next
presentation
presenter
first?
is, I don't know, well, they're still.
Okay. Dr. Andre, can we have this presentation first, then the next presenter will follow?
I've got it on a memory stick. I don't know if
Maybe
that
we
will
can
help.
load it again.
Okay.
Okay, so let's, here, it's here already. Okay. Sorry.
Thank you. Anyway, I'm presenting this session on behalf of the colleagues from Bangladesh. I'm part of the team, TB Care 2, that also worked in Bangladesh. And our focus today really is to present the work that was done jointly with the Ministry of Health in Bangladesh and the TB Care 2 team on the transition from hospital management to community management. So TB Care 2 is a USAID-funded project, and that worked in Bangladesh from 2011 to 2015. And the project supported the National TB Control Program generally on issues related to tuberculosis for both susceptible and drug-resistant TB, with the intention of reducing morbidity and mortality due to the disease. The project worked jointly with the Ministry of Health from the onset to introduce community-based MDR-TB. There were several partners that were involved in this process. We've said these were our government counterparts, TB Care 2 team, Partners in Health, the World Health Organization, local groups, and research groups. Now, just a little bit about epidemiology of TB in Bangladesh, high rates of tuberculosis, especially for MDR-TB. This is updated data. The TB prevalence stands at 411 per 100,000 with an incidence of 225 per 100,000. And in 2014, 4,700 cases were confirmed or diagnosed with MDR-TB. And this is the data according to the last DRS, where 1.4 of all the cases of new cases were diagnosed as drug-resistant TB, and 28.5 of the retreatment cases were diagnosed with MDR-TB. Now, what was the reasoning for this? Bangladesh has got a population of 160 million people, and for the entire country, there was only one site that was managing MDR-TB at the central level. So even though the number of cases that were being diagnosed on an annual basis was not high, but there were very long waiting periods, at times up to 3 months. And at this stage when patients are waiting to be admitted to the hospital, they would be at home. And further complicating this, there were also long hospitalization periods where patients had to be on treatment at times for the entire period of 20 to 24 months. There were limited initiation sites, diagnostic sites were also limited, and this further really, the infection control was poorly implemented, especially in this central hospital. Now, when the TB Care 2 project work started, we worked jointly with our counterparts at government level, and it was agreed upon that 3 sites should be established as a pilot. And this also coincided with the time when Expect was introduced. Teams were formed that comprised of different partners, clinical, community, NGOs, and research groups. And one of the main processes really from the onset was the development of SOPs to guide the work. Training materials had to be developed, and reporting and recording tools had to be developed to ensure that all sites from day one of initiation of treatment would be able to record the number of patients. There was also a need, of course, to increase the number of MDR-TB beds. In the site that was managing patients, this was a hospital that had about 200 beds, and each and every site, an additional 60 beds were identified for hospitalization of the patients. And as part of the SOPs, also there was a system to ensure that psychosocial support and there's nutrition also patients was included. And also an exciting project, which I think would be relevant for here, was the introduction of mHealth for monitoring and supervision of treatment. So just to tell you a little bit about the mHealth project, which was also introduced. This is a system that was being utilized by the DOT supporters on a daily basis when they go and visit the patients. And the good thing again about it, it was real time, and at any day one would be able to tell how many patients have taken their doses on that specific day, and if there were any problems that were picked up during that visit. Some of you might have attended a session already discussed yesterday, discussing the social protection for TB patients. The same system was also used to transfer funding for both the DOT supporters and the TB patients, like a stipend on a monthly basis. So in a nutshell, this is some of the data from 2008 to 2012. The difference between the number of patients that were diagnosed and enrolled on treatment. And the work started in 2011, on an annual basis, about 500 patients, and 348 patients were started on treatment. I'll get back to this later. So I think one of the some of the key results since the introduction of community-based MDR-TB, the first one really was the rapid transfer of patients to community. And this increased on an annual basis from 390 when the project started, and to approximately 1,200 patients in 2014 were transferred from hospital back to the community. I must also stress that it was still the policy that whether the patients were able to be initiated treatment from day one at home, they still had to be hospitalized for a specific period to ensure that counseling was provided, patients understood what regimens they'll be on, and a supporter is identified close to the family who also had to go through counseling and also understand the importance of infection control. So the treatment initiation delays after the diagnosis really reduced for more than 2 months up to really a week or two. And what also was very interesting was in the improvement in the treatment completion, which was very low to less than 50% when the project started. This is results of some of the work that has been done under TB Care in relation to the project in Bangladesh. Now, just to highlight, maybe also to confirm the presentation that was done earlier, I think from South Africa. Despite all of this, for the initial pilot sites, the most interesting factor was the reduction from the time diagnosis was made to treatment initiation. These are the 3 sites nationally. In 2011, medium patients had to wait up to 70 days to actually be initiated treatment. And by 2014, the most that patients had to wait was 6 days. And I think also the ability to introduce community-based MDR-TB with the introduction of expert made the biggest difference. So this was the same in all the first sites where CPMDT was introduced. And my presentation really was to focus on some of the key lessons and the components. And I would just like to highlight a few. That training of all staff that are involved with this process is quite important. And it's not only training of the doctors and the nurses, but the communities and the patients that are going to be initiated on treatment need to be included in the process. Materials were developed both in, but also in local languages, and each and every patient has to go through a counseling session before treatment is initiated. These are examples of our partners who helped us to actually go out and look after patients to ensure that side effects were being managed. This again is a session of counseling being held with the patient. On a daily basis, a DOT supporter would go to the home to meet with that patient to either give the drugs or to give injections, especially for the first 6 months of treatment. And the DOT supporter has to sit with the patient for at least 30 minutes to ensure that the patient tolerates treatment. Cash transfer, I strongly believe, played a major role because many of these patients were poor, but with that little funding that they were being provided, they were encouraged to buy extra food and also to support their families. And with all of this, the regular monitoring, the supervision, it really was not just going to the lower levels to check the records, but to also make sure that the communities and staff at district level also felt that their work was valued, and also the team at national level was able to address any fears that they had, because the process was really cumbersome, and for people to accept to supervise MDR-TB patients is not an easy thing. I think in conclusion, what I would say is that community-based MDR-TB really showed great potential in Bangladesh and continues to show good results. The quality of services is important. It was not just getting more patients being diagnosed, but also making sure that they are started on treatment. And the results that have been achieved to date really show that whether a patient has drug-resistant TB or not, it is doable or it is possible to get high cure rates, minimal interruption, and really reduce the risks of getting patients failing treatment. I'm not sure why my slide to thank everyone now is refusing, but anyway, the intention was to thank you and also acknowledge our colleagues here from the Bangladesh National TB Control Program. I can see the team also that worked in Bangladesh as part of TB Care 2, the WHO team, local NGOs, and lastly, the patients who really trusted us to put their health into our hands. And I'm proud to say there are many patients who are alive today who I don't think would have had that opportunity if this project, jointly with the ministry, did not provide the service. Thank you.
Thank you very much. So we'll move on with the next presenter, and we'll have the questions after all are presented. So the next would be the integration of MDR-TB contact tracing as part of DOT is efficient and cost-effective. So let's welcome Dr. Paul Daro from Bangladesh.
Good afternoon, and I'm happy that this is this is great coincidence because I'm also from Bangladesh and presenting on integration of MDR-TB contact tracing as a part of DOS is found to be efficient and cost-effective. This is actually part of what my previous presenter has presented. This is one part. So. Contact tracing of index TB patient is simple and effective way for early finding of cases to reduce further transmission and initiation of treatment for better outcome. While contact tracing has been used extensively as control strategy for TB in developed world, it is uncommon in developing countries with high prevalence like Bangladesh. Investigating the contact of indexed MDR-TB patient is utmost important to diagnose the cases early and reduce the transmission. Through technical support of USAID TB Care 2 project, NTP Bangladesh has taken a special initiative to contact tracing of MDR-TB patient, which is found to be effective, inexpensive, and simple. The current DRTB management strategy, that background has already been detailed described by my previous speaker, so I will skip this. This is in Bangladesh, the strategy is adopted in 2012. So I'm going directly to the intervention. What intervention TB Care 2 project taken for diagnosis? This is the first intervention, contact tracing integrated with the daily dots. So the intervention was started from February 2014. And contact tracing is integrated with routine administration of DOT and MDR-TB for the MDR-TB patients. So before that, a simple tool was developed to recording tool, which was used by the DOT providers and kept in the treatment chart of the patients. Actually, the DOT providers, while visiting patients at home for administration of DOT, the DOT providers also investigate symptomatic TB cases among the family members of the patients. Any symptomatic contacts are referred to expert site, and of course, they recorded all these, family members and number of symptomatics in the recording tool. A second intervention, as Bangladesh now doing M-Health, actually to monitor the patients, and this contact tracing again integrated with the M-Health system. DOT provider investigate for symptomatic in the family and report contact tracing data through M-Health. Actually, in M-Health, there are a lot of things, and at the end part, it was integrated just few questionnaires, like any symptomatic, yes or no, referred to expert site, yes or no, result, not TB, TB, RR. So these, by this reporting, immediately in the PC interface, people can see that whether there is any contact or not. And contact tracing is integrated with regular monitoring and supervision. While supervisors are going to supervision, this is also their mandatory activity to look for contact tracing. And first of all, they supervise and monitor whether the contact tracing is done by the DOT provider or not. They will check. If this is not done, again, they will give feedback, and also they themselves will trace out any of their symptomatics and refer to the expert site. So result, this is actually result of 19 districts result. So as I have said that the intervention started in 2014. So from February 2014 to June 15 in 19 districts, total 559 index MDR-TB cases were visited by, the index cases are investigated. Total 1,854 contacts were screened. From those households, 825 symptomatic are found and tested by gene expert. Out of those symptomatics, 66 are found to be MTB positive and 18 are found to be rifampicin resistant. So in small highlights and referral of all symptomatics, if we see the result, all the symptomatics, 100% symptomatics are ensured to refer to the expert site. And also after referring, they achieved 100% compliance for testing of contacts by the gene expert. And approximately 8% of the symptomatic cases are found to be MTB positive, and approximately 2% of symptomatic cases are RIF resistance, and none detected from under 5 children from this contact tracing. So adoption and integration of contact tracing with DOT and routine monitoring visit could help find more MDR-TB cases early and ultimately reduce the residual transmission of MDR-TB. Eliminate the need of field staff to go to the patient's house for contact tracing separately. This saved time of field staff who can now spend more time on other important project activities. This is found to be efficient and effective. So thank you.
So let's have the next presenter that will share to us the burden of MDR-TB among contacts of MDR-TB cases, results from routine program implementation in 2 regions of Ethiopia. So Muluken Melese.
Yeah, thank you, Chair. Unfortunately, I am presenting on behalf of my friend who was denied visa to come to UK. So this is a USAID-funded project in Ethiopia, and we're supporting 2 big regions with a population of around 55 million. And my presentation is somehow similar with the Bangladesh experience, but they have proceeded with, mHealth, and we're still a bit far from that, and we are learning from you as well. As a background, I think investigating household contacts of MDR index cases is very vital. And in our national guideline, it's one of the recommended strategy, to identify MDR-TB cases. And from even our field experience, I have seen one teacher whose 3 brothers were also having MDR-TB, in the field. So it's a good entry point and a low-hanging fruit. We're not using it, efficiently, especially clinicians, they were not much involved in screening. But now we are integrating, clinical practice with our community practice, and contact investigation is part and parcel of, the clinical care as we speak now. So our objective was to assess the yield of, MDR-TB screening in the 2 regions we supported. And the evaluation period, covered between October 2014 and December 2015. Our project initially was not focusing on MDR-TB, but, as we go along, we realized that, MDR-TB service is very much neglected. And in collaboration with USAID, we introduced MDR-TB as one of the components of our project, which was a good introduction as far as we are concerned. Just to mention some of the interventions, they somehow overlap with the Bangladesh experience. Our ministry endorsed, systematic TB contact screening for MDR-TB index cases. We also supported staff training, not only the clinicians. We also have, what we call health extension workers, who are, community carriers in terms of, health program in our country. So those people are also trained on MDR-TB contact investigation, as well as TB infection control, at community level, because infection control should also be part and parcel of, the approach. Mentorship was very crucial. In our project area, we have ongoing mentorship by immediate supervisors. We also have, quarterly mentorship by zonal and district health officers. They go and, check whether or not the program is running properly, one of which being, contact investigation. We also prepared and distributed standard operating procedures, and we also provided recording and reporting forms. The standard recording and reporting form didn't encompass, contact screening, and we, in consultation with the regions, we also came up with recording and reporting tool for MDR-TB contact screening and case finding. As you can see in the slide, this is the procedure of screening. So we check whether or not there is a contact with the index case. If there is a contact, we screen for TB symptom. And if there is TB symptom, gene expert test is done. And for those who didn't have TB symptom, we have a mechanism of, doing repeated contact screening every 3 months until the patients complete the 2-year treatment. Because, some of them might be at the earlier phase, or there might be ongoing transmission. So to cater for that, every quarter until the patients complete treatment, we do contact screening using our clinicians as well as our community workers. And regional health bureaus and the national TB program is highly involved. And family members and other close contacts are invited to the health facility if they could. If they couldn't, we have our health extension workers who are community health workers, and they do the screening at household level and also do counseling, sensitization, and things like that. When you come to the result, it was just during that specified time period, and in the 2 regions, we had around 272 MDR-TB index cases who had around 704 contacts, and 30 of them were, presumptive TB. They had showed signs and symptoms of tuberculosis, and we identified 11 cases of, tuberculosis. And if you compare the notification rate from our screened people, it was around, 1,563 per 100,000, which is 7 times the yield compared to the national TB prevalence, which is around 200. In conclusion, I think the yield of MDR-TB among contacts was 7 times the national prevalence. And if you see in a place where there is poor infection control, I have mentioned that even 3 people were found from a single index case. And there are a number of, similar stories in the community, especially in rural setting. So it's more pronounced in some focal areas who are not, having poor housing, who are having poor housing conditions. And if you see the yield, it was also, 1.7 times the yield of TB among contacts of drug-sensitive TB cases. 1.7 times the yield in the contacts of drug-sensitive TB index cases. Contact investigation for MDR-TB index case needs to be a standard practice. It's already standardized, but it needs, close monitoring and availing, the diagnostic service. And in our country, because we are providing screening all over, the service should be there. And expert service is well decentralized. And we also started, specimen referral using cold chain system, so that whatever screening we do, it should also be, linked with screening service, namely gene expert in our case. And experience of contact screening for drug-sensitive TB index case helped in expanding the service to MDR-TB contact screening. We used our experience in drug-sensitive TB contact screening, especially using, the community volunteers or the community health workers, as well as the clinicians in doing screening for tuberculosis. Thank you very much.
Thank you very much. Thank you to all our presenters. We don't have time for questions. So, as a conclusion, what was provided to us that for us to increase the enrollment, to increase the finding of TB cases, we need to expand our services by expanding the services to all the facilities. We need to have an expansion of the diagnostic and treatment facilities, and there should be a link in the diagnosis and the treatment. And we should not also forget that there should be a contact tracing as presented by the last two presenters, that this would also increase our yield for our MDR-TB cases. So thank you very much.
Dear participant, thank you very much for the participation section, and fantastic. The speakers presented the international researches. It's very nice to hear and to find that many international groups to implement the main pillars of NTB strategy. It's centered approach for TB patient care and accelerated innovation and bold policy. It's very nice that you implemented this as a researches in your practical. And thank you very much, international organization, USAID, and other who financial your research work. Thank you very much, and good luck.